Welcome to today's video. We're diving into a fascinating conversation with Dr. Mohit Khera.
Yeah.
What is the sex span and why do you care about it?
Yeah, so Stephen, you know what lifespan is. It's how long you're going to live, right?
A leading expert in men's health and erectile dysfunction. In his podcast with Stephen, Dr. Khera breaks down why 60% of men experience erectile dysfunction and what can be done about it. Stay tuned for insights that could change the way we think about men's health.
Who are you and what have you spent your life doing?
So I'm a urologist, and I specialize in male and female sexual dysfunction, testosterone replacement therapy, and infertility. For the past 17 years, I've been working as a professor at Baylor College of Medicine in Houston, looking at ways to improve sexual health, improve testosterone, and improve fertility.
Dr. Mohit Khera introduces the concept of the sex span, the total duration of one's sexual health over a lifetime. He explains why it's crucial to focus on improving and maintaining this aspect of well-being. By understanding the factors that affect your sex span, you can take actionable steps to enhance not just your performance, but your overall quality of life.
And we talked just before we started recording about this term sex span, which I've never heard before.
Yeah.
What is the sex span and why do you care about it?
Yeah, so Stephen, you know what lifespan is. It's how long you're going to live, right? And you also know what health span is, how long you're going to live in a healthy lifestyle.
Mm-hmm.
But you may not have heard of the concept of sex span. Sex span is the ability to engage in sexual activity, satisfying sexual activity. And so how long you are able to engage in sexual activity is important to most men, right? So let's give you an example. The average lifespan in the United States is 77 years old. The average health span in the United States, believe it or not, is 67 years old. In fact, if you look at the CDC and they talk about how long you'll live without a disability, it's actually 63. So there's a delta here. There's at least 10, 15 years where you will be in some kind of disability and cannot live to your fullest. Now think about the concept of sex span, how long you'll have the ability to engage in sexual activity, satisfying sexual activity. Most women, want their sex span and their health span to last as long as their lifespan.
Yes.
So I think it's important.
And there's things that I can do to make my sex span last as long as my lifespan.
There's many things you can do, and I call it the 4 pillars. The first is diet, exercise, sleep, and stress reduction. I don't have a pill on the planet stronger than diet, exercise, sleep, and stress reduction. And each one of those can significantly improve a man and a woman's sex span, but also their health span and their lifespan. The other is hormones. Testosterone, extremely important. Testosterone supplementation can significantly improve a man and a woman's sexual function. And unfortunately, for women in the United States, we don't have very many options. Actually, globally, for women, there's not many options. But I think it's important, hormone replacement therapy. And one more thing, I think about the couple. Think about sex span as a couple's disease. Let me give you an example. Tomorrow, Stephen, are you married or?
Yeah, well, I'm in a long-term relationship.
Your partner. So let's say your partner tomorrow says to you, I am no longer going to have sex with you. Unless you cheat on her or you leave her, you're not going to have sex again, right? Think about the importance of the couple. So I talk about this quite often. Keep your partner engaged. Keep your partner healthy if you want to prolong your sex span.
So I've got 2 questions here. The first of which is, who have you worked with in your career? And the second question is, what is your CV? Give me a rundown of your professional experience.
Yeah, so I started my residency in 2000, and I did my residency in 2000, 1 year of general surgery. I did 5 years of urology training, and then I did 1 year of a fellowship in men's health. As soon as I finished my training, I joined the university at Baylor College of Medicine, and I started a basic science laboratory where we do basic science research in sexual medicine and testosterone for the past 17 years. And I just started a clinical trial, so I have a clinical arm where we do clinical research. I see approximately 150 patients a week, every week. I do approximately 6 to 8 surgeries every week. And I still work at the VA hospital. It's a veteran government hospital, 1/2 day a week, working with the veterans. So it's quite busy. But, my passion really is education, research, and clinical care. And that's what we do. And so, when I started how I really got into this was when I finished my training, I was so proud of myself. I was able to get these men, these amazing erections, these great libidos. And I realized one day this woman called me and she was frantic. And she said, look, you're treating my husband. You're able to get him these great erections, great libido, but I don't want to have sex with him. And he wants to have sex with me all the time. And now we have a terrible relationship. You've ruined our relationship. And I thought to myself, wait a minute, this doesn't make sense. But she was right. In sexual medicine, either leave both libidos low or raise them both, but don't raise one or the other. It's a setup for disaster. So very quickly that year, I went out and flew out to meet with Dr. Irwin Goldstein, who's considered one of the godfathers of female sexual dysfunction. I spent some time with him, went to his courses, and so for the past 16 years, I've been treating women as well. You can't just treat one patient without addressing the other. And so therefore, it's a couples disease.
And give me a flavor of the types of conversations you have on day one when they walk into your practice, when they come to see you. What is the issue that they say they have, and how do they express it? Like, what are the words that they use? And if you could just give me like 5 of the most popular things people say to you when they come to see you.
So listen, first of all, men and women are very different how they express it, so we'll talk with men. Most men, let's backtrack. Most men and women do not get any kind of medical care when they see their primary GP. In fact, most GPs don't address sexual dysfunction. There was a study looking at medical students. Only 65% of U.S. medical students get training in sexual medicine. And of those 65, 50% of those students said that the training was terrible. So we don't get the sexual medicine training to address the problem for patients. So the majority of patients are never discussed about their sexual problems. But when men come in, most of them are coming in because they already have tried some medications that haven't worked, and they're looking for other solutions. Now, there's two simple questions you can ask a man. They're very straightforward. Are you able to get an erection sufficient for penetration? It's either yes or no. And are you able to maintain that erection till orgasm or pleasure? It's either yes or no. If he answers no to either one of those questions, he suffers from erectile dysfunction, right? And so it's very important to get a detailed history. You want to ask particularly, are you able to get an erection on your own? Are you able to get an erection with masturbation? Do you wake up with morning erections? If he says, look, doc, I get great morning erections, or with masturbation, I have great erections, then this has to be psychogenic, right? With my partner, I cannot get an erection, but when I'm by myself, everything works fine.
Psychogenic.
Psychogenic ED. It's a big component.
What is psychogenic?
Mainly something in the mind that's bothering you or inhibiting you from engaging in sexual activity. And that's where the sex therapist comes in, right? Because if someone tells you, I get great erections by myself, but with my partner, I'm not able to get good erections. Psychologically, when they're with their partner, they're not able to achieve a good erection. Sex for men and women has a huge psychogenic component, So I think it's very important to get detailed history. Are they able to get erection? What have they tried? What medications have they tried? You have to query about depression. 66% of men who come in with ED have some degree of depression, 66%, right? And that's important. Anxiety, 35% is very important. And more importantly, we'll talk about this. ED is the first sign of other major adverse medical problems. For example, if a man comes into my office today, 15% of them will have a heart attack or a stroke within 7 years. 15%. The day they get ED, 15% will have a heart attack or a stroke within 7 years. It's the first sign. Other studies, Dr. Montorsi showed that if a man presents to the emergency room with a heart attack, on average, 39 months earlier, that's when the ED started. So it is the first sign. Now, there are many reasons for this. One theory is called the arterial diameter theory. The penile arteries are the smallest arteries, 1 to 2 millimeters. The coronary arteries are 3 to 4 millimeters. The carotid, 6 to 7 millimeters. So if you remember from physiology, if you're going to block an artery, 50% occlusion of an artery causes damage. So if you're going to block an artery, you're going to block the penile arteries before the coronary arteries. You're going to block the coronary arteries before you block the carotid, right? Mm-hmm. So men will get ED before they get a heart attack, more likely to get a heart attack before they get a stroke. That's a theory, but it makes sense. So I worry when a man comes into my office, could this man have occult cardiovascular disease? In fact, there was a wonderful study that came out of Greece. They looked at 50 men that walked in, and they gave them an echocardiogram or stress test. If it was positive, they went on to a coronary angiogram. What they found is that roughly 20% of men, 1 in 5, actually had some occlusion in their heart, whether it was 1 vessel, 2 vessel, or 3 vessel disease. So I think to myself, every time I'm writing that prescription, is this one of the 5 that could have some occlusion? And is there an opportunity to intervene at this point. So it's really important to think about cardiovascular disease as well.
One of the big subjects that I hear a lot about, even in my friendship groups, is about libido. I've got so many stories in my friendship group of either one or both partners losing their libido. So on this subject matter of libido, it's kind of where I wanted to start this conversation. What is the most frequent and popular reason why men and women struggle with libido problems? And how much of that is about compatibility?
Yeah, good question. Libido is multifactorial. There's many pieces of libido. It's very complex, and I'll give you some important components. First, it could be hormonal. And the mnemonic I teach the residents is PET. The 4 hormones that can affect someone's libido are prolactin, estrogen, thyroid, and testosterone. So you have to check the PET. If the prolactin's elevated, the libido goes down. The testosterone's low, the libido goes down. So maybe it's a hormonal issue, which could be it. And particularly many women who go through menopause suffer from hormonal issues, and it could be a hormonal issue. The second is something called neurotransmitters. So in other words, serotonin, norepinephrine, dopamine. Dopamine goes up, libido goes up. Serotonin goes up, libido goes down. So these all regulate how someone's libido will function. So one of the biggest culprits for low libido are antidepressants. What do antidepressants do? They increase serotonin and they decrease libido. So sometimes it's a medication or something that a patient's taking that will shut down their libido. For example, a medication that men take for urinary function called finasteride shuts down their libido. So there are certain things that you have to look at. The other components are lifestyle. Diet, exercise, sleep, and stress reduction, particularly fatigue and stress. If a woman is tired and she's exhausted and she has to choose between sex and sleeping at night, many times she may choose sleep, right? I'm just saying, right?
Yeah.
So fatigue is important.
Yeah.
Stress, and there's this cliche, this mnemonic, this saying that with stress is kind of interesting. Typically, if a man has a very stressful day, he will want to have sex to relieve his stress. Women have to relieve their stress to engage in sexual activity. It's kind of the opposite. You know what I mean? So I tell men, if you really want to have sex with your wife, do the dishes, take out the trash, do everything you can to tuck the kids in bed early, relieve her stress, because that will significantly increase her desire to engage in sexual activity. But the other one is psychogenic. So, we talked about that earlier. Sex has a huge mental component, your relationship with your partner, how close you feel with your partner. So sometimes patients come to me and they're in an abusive relationship and they say, give me the pill that improves my libido. I say, it's not going to work. I mean, the essence, the core, the foundation is not working. And therefore, it's really important for them to see a sex therapist. One thing for men that actually shuts down their libido is when they start developing erectile dysfunction. So if a man starts getting erectile dysfunction, let's say he gets a good erection 50% of the time, and he's starting to have some problems, and it's 10 o'clock at night, and he says, look, I can try to engage in sexual activity, but it may or not work, and it may be frustrating and embarrassing, or I can just go to sleep. He's probably just going to go to sleep, right? And it becomes a vicious cycle because the less sex he has, the more difficult it is to engage in sexual activity later on. And so you may interpret this as a low libido, but he's really just avoiding it because he doesn't want to deal with it, right? But the partner also looks at this as maybe I'm not attractive anymore. Maybe there's something about me that's not appealing, and it becomes a vicious cycle. So one thing you can do is significantly improve the quality of the erections in a man, and that actually helps improve his libido. So for example, if I tell a man, if every night you have a great erection, and every morning you wake up with a great erection, what are you going to probably do? You're probably going to use it, right? So libido inherently goes up, right? So I think ED and libido are tied very closely.
How do you define the term libido?
It's a desire to engage in sexual activity, right, for men and women. And you have to, when it's a true problem, they have to be bothered by the condition. So I just want to be very clear. There are women who have low libido and say, I really don't care. I'm happy that I have a low libido. Well, then it's not an issue, right? You have to be bothered by the issue.
So on this psychogenic element where it becomes a vicious cycle, I've seen this in my own life several times, well, at least once. And I've seen it in some of my friends where because there's a bedroom issue, when you go to the bedroom, you're both a little bit anxious, and then one of you can't perform. And if you can't perform, it exacerbates the issue. And it creates this sort of vicious downward spiral of like, it makes the bedroom like a really awkward place to be. And this is how I think about when you're talking about psychogenic component. So in the case of erectile dysfunction, if you're thinking as a man, God, if I go to the bedroom, I'm not going to be able to get it hard. I'm not going to keep it up. It's going to be embarrassing. She's then going to ask me questions. She's going to think I'm not into her, which all just makes it even harder. Because as a man, like, I perform best when I'm really not thinking about it and I'm like not anxious and when I'm stress free.
Right.
And it seems to me that the like antithesis, the opposite of great sex is like overthinking.
You're 100% correct. And this is what happens. Let's say a man gets ED just one time, young man. He says, that was really odd. And what's wrong? You know what he does next time he has sex? As he's having sex, he says to himself, I hope I don't lose my erection. I hope I don't lose my erection. The second he says that to himself as he's having sex, he's going to lose his erection, right? Because he's so worried that he's going to lose the erection and not enjoying the experience. So now it's happened twice. So now he engages sexually the third time. And now he's even more freaked out because it's happened twice. And it happens again. We call this the vicious cycle, right? Because now sex has become an anxiety event, an anxiety-provoking event. And so you really have to work on decreasing that anxiety and not thinking about it. That's where sex therapy comes in hand. And that's where a medication called daily Cialis has become unbelievably helpful for my young patients. Because daily Cialis is a medication that men take daily. You've heard of Cialis, right?
It's like the Viagra.
Yeah, it's like Viagra, right? So there's Viagra, there's Cialis, Levitra, there's Stendra. There's 4 different brands. But one of the 4 is meant to be given daily. It's a lower dose, 5 milligrams every day, and the larger dose is 20 milligrams. When you give a man Cialis, 5 milligrams every day, what it does is essentially is having that medication on board all the time. When he engages in sexual activity, he doesn't have to take a pill. He just has sex whenever he wants to. And I found that to be unbelievably helpful in breaking psychogenic ED. Because now that's exactly what that is.
On the table.
Yeah, that's exactly what it is. Yeah. And so these are pills that are in the U.S. But what's nice is they used to be very expensive. Now if you look at Mark Cuban and a lot of the good RX companies, men can get 90 pills for $15 or $20, which is very cheap.
You use the word young men.
Yes.
Young men presumably shouldn't be taking pills.
They shouldn't, but what happens when they have psychogenic ED, because they think about it the most, is they need to break the cycle.
What's the cost? Because I'm going to be honest, I'm a pill skeptic.
Yes.
So I try and avoid taking pills to solve my problems.
Yes.
If I can.
Right.
Obviously, there's going to be situations where I can't.
Right.
And I accept that. But my bias is towards figuring out if there's another way before I take a pill.
Right.
Because everything in life comes with a cost, all things.
Yeah.
So there must be a cost to taking a pill to solve this problem.
Well, the actual monetary cost is unbelievably cheap.
Monetary cost is, I'm thinking about like, do I then get dependent on this?
Yes.
Do I have to take this for the rest of my life?
So there's no dependency. Let me tell you why I think that drug is so important. That daily Cialis has one of the only things, in my opinion, that actually reverses erectile dysfunction. So let's backtrack. I'll give you an example. Let's say today you break your leg, okay? I have 2 options, Stephen. I can fix your leg, or I can give you Vicodin, a narcotic. And if I give you the Vicodin or the narcotic, you'll still be able to walk until the Vicodin no longer works and we're in trouble. Viagra is a Vicodin. It is not a cure for your erectile dysfunction. It's just masking the problem. Daily Cialis, in my opinion, is one of the few things that helps cure ED. If you look at studies and you look at a penile tissue and we biopsy the tissue and then you biopsy 3 months later on daily Cialis, it physically gets stronger. So let's say you go to the gym today and ask you to lift dumbbells. What's going to happen to your arm? It will hypertrophy. With daily Cialis, we see hypertrophy of the smooth muscle, meaning it gets physically stronger. So in my opinion, it's one of the best things to prevent ED in the future, help reverse the ED process. More importantly, daily Cialis protects the endothelium, and we have to spend some time talking about that. That is the lining of the blood vessels. It's the brains. And the lining of the blood vessels is very important because once that gets injured, you start getting clot or plaque, which will get a heart attack, a stroke, and erectile dysfunction. So it protects the lining of the blood vessels. 2 other indications. It's FDA approved to help a man urinate better, FDA approved. And it's FDA approved to protect the heart in terms of something called pulmonary hypertension. So in my opinion, it's an excellent medication. Patients say, do I get dependent on it? I say, you do not get dependent on it. And I feel like you're better had you taken it than had you not. You take it for 3 months, you get strengthening of the penile tissue.
What happens if I stop taking it?
If you stop taking it, There's a wonderful study by Aversa, and what he showed was that those patients that stopped taking it after 3 months versus placebo still had benefit in terms of endothelial function protection and erectile function protection than those people that took placebo. So thinking about saying, hey, if I go to the gym and I work out for 3 months, what happens if I stop? I say, well, Stephen, you're better off had you gone to the gym for 3 months. That's my opinion.
What is the downside?
There's side effects. So every drug has side effects, right? But they're low with 5 milligrams. Back pain, stuffy nose, headache can occur in these, but it's quite small. But I do think that this is one of the medications that really can make an impact in men's health. Think about it. If I told you there's a medication that protects your heart, helps your prostate, and helps men with erections, and it's affordable, I think that most men would say, I'm in.
What are the big side effects that people report when they're on Cialis?
So on the larger dose, headache, stuffy nose, back pain is more common with Cialis and other medications, but it can be reported. Remember, you shouldn't take these medications if you're taking a nitrate because it can drop your blood pressure. But other than that, these are very commonly used medications throughout the world.
And they're not suitable for certain people that have certain cardiac disorders, I'm guessing?
Well, the way this was invented, the first one, Viagra, came out in 1998. Viagra was in the clinical trials designed to be a blood pressure medication, and accidentally men were getting erections in the trial. So these medications are, in my opinion, cardioprotective. A very famous physician named Dr. Kloner published an article recently showing that those men who took daily Cialis had a 13% reduction in cardiac events and a 25% reduction in mortality. It just came out because of the potential effects of protecting the endothelial lining of the blood vessels.
How does this work to solve for the sort of psychogenic component that we talked about, that vicious cycle people get into with, like, I'm guessing you're telling me that it increases your probability of having a good erection.
Right.
But this still isn't really working on a libido, is it?
Right. So let's say you started falling through the vicious cycle and you started having ED and it was 2 times, 3 times. And now I put you on this medication. And every time you have sex, you have the most amazing erection of your life. And 30 times, 40 times, 6 months go by and you're having these amazing erections. You're relaxed and you're calm. Then I start going to every other day. You still get amazing erections. Then I go to once a week. You still get amazing erections. Then I stop. You still get amazing erections, right? I just need to show you that everything is perfect again. And that has a huge value.
What about for women?
This is the unfortunate part. We don't have a lot of treatment options for women. And if you look about it, if I want to give you an example. In 2015, if you and I went into the drugstore in the US, Walgreens, and said, give me all of the drugs to treat men for sexual dysfunction, they would put 30 drugs on the counter. These are all the wonderful treatments for men. In 2015, there was not a single FDA-approved drug to treat women for any sexual dysfunction. Very sad. In 2015, the first drug to treat women for female sexual dysfunction came out, and it was called Adi, or flibanserin. And flibanserin basically is a drug that a woman takes every day and increases her desire for sex. That's it. That's the FDA indication. Increases her desire for sex. Several years later, the second drug for women came out. This was called Vyleesi, or bremelanotide. Essentially, it's an injection that she takes 45 minutes prior to intercourse, and it increases her desire for sex. But again, we have only 2 drugs. The reason being is because the research, the funding that we have for female sexual dysfunction is far less than we have for male sexual dysfunction. And it's unfortunate because, as I mentioned earlier, this is a couple's disease. And so many times I have to use drugs that I use for men to help treat women. So I do use Viagra for women, but Viagra for women helps arousal. So let me explain. Female sexual dysfunction has 4 components. 1 is decreased libido. The second is decreased arousal. Third is orgasmic dysfunction. And the fourth is pain with intercourse. These are the 4. If a woman has any one of these 4 and she's bothered by it, she suffers from female sexual dysfunction. In the US, roughly 43 to 48% of women suffer from female sexual dysfunction, significant number. Only 19% seek therapy, will get therapy. So there's a huge number of women that I say are suffering in silence. They suffer from the condition. They don't know where to get help. And unfortunately, there are not many treatment options available, right? So it's a big problem and a big unmet need.